So what causes Parkinson's? What's the molecular underpinning of Parkinson's really is important to understand if you want to understand how we're approaching treatments. So I'm going to try to give the whole story, but not a lot of details, maybe a few examples. So I'm going to go through a lot of things very quickly. If I do, they're not that important. Again, it's just the story. So get started. So I do want to say that I'm clean. I don't take any money from pharmaceuticals, but I do work with them in developing new drugs and therapies, and these are just some of the companies that we work with to do clinical trials and that sort of thing, to be completely transparent. Okay, so I want to start out by what causes Parkinson's, and that's basically how I spend a lot of my time doing research, is trying to understand the causes of Parkinson's and the molecular basis of it. So I'm going to try to review that a little bit, how to prevent it. Once you understand at least some of the causes, we can then start approaching how we can prevent Parkinson's. It is increasing with time, so we need to really act. We really need to, thank you. We really need to try to lower the incidence. It's a lot easier to treat if you never have it. And then talk a little bit about how we're trying to slow the progression or stop it from getting worse, and that's really the holy grail. But symptomatic treatments are extremely important for those who already have Parkinson's. So I'm going to try to cover a lot of things here. So the point of the very first slide is that Parkinson's does not start when your tremor starts. It starts decades before. So it's a very, very long process. They call it prodrome now. They call it a prodrome. It's really the beginning of the disease. So it may start with constipation, a little bit of loss of sense of smell. You may start acting out your dreams, called REM sleep behavior. All of those are the beginnings of Parkinson's disease. But those are common. Everybody who has constipation is not going to get Parkinson's disease. So you don't know until you start getting the tremor or the stiffness. But you can see you're halfway through it already. So this is where it starts for patients, but for those of us that's trying to understand the causes of Parkinson's, we start way back here. So this is what most people start their talks with. This is the classic substantia nigra, the black substance here in the middle of the brain, you can see up there. And in somebody with Parkinson's, this is their brain, and you can see how pale it is here. And that's due to the loss of dopamine cells. And I think everybody in this room has heard dopamine to the blue in the face. It's not all about dopamine, but that's one of the things that that causes this, that lets you know you have Parkinson's. That's what causes the rigidity and the tremor, are the loss of these neurons here. This is called a Lewy body, and that's what identifies Parkinson's under a microscope. And we've learned that this Lewy body is filled with a protein called alpha-synuclein, and that is critical to Parkinson's disease, is understanding the function of alpha-synuclein. Now, there are many, many other molecular components that are involved, and this is just one of many, but this is definitely key. We know this because if you have a mutation in the gene that codes for alpha-synuclein, you get Parkinson's. If you make too much alpha-synuclein, you get Parkinson's. We can give alpha-synuclein, express it in animals, and they get many of the components of Parkinson's. So we know that this is important. It's not the only way you can get it. There are other types of Parkinson's disease that doesn't include alpha-synuclein, but the vast majority do. Okay, so alpha-synuclein is this protein, and it normally lives in this very unstructured configuration, but it can misfold and start clumping up. It gets into these balls. We call them oligomers, protofibrils. There's a lot of names for them, but they're abnormal balls of protein, and that is what's toxic, and that injures the cells. It's as simple as that. And then if they form these more complex structures called fibrils, they actually form the Lewy body itself. So we think it could be either the oligomer or the fibrils that are toxic, maybe both, but it's this abnormal conformation and aggregation that underpins the toxicity of alpha-synuclein. And what we've learned in the past few years is that it starts in one place and then it can spread. So it actually can start, it forms either fibrils or oligomers, and then in the neuron it forms, it releases it, and then a neighboring neuron takes it up. So it slowly spreads from one neuron to another. And this turns out to be probably a mechanism for all neurodegenerative diseases, including Alzheimer's disease and a variety of other ones. So thinking back to the very first slide, I said 20 years ago is when your Parkinson's really started. Well, that's because the alpha-synuclein is aggregating in your gut. And that's where we think it starts. It starts in your gut. There's also a place called the olfactory bulb. We see it very early there. And then it slowly transverses through a nerve called the vagus nerve and eventually enters the central nervous system, your brain stem. Now, this is not universally accepted. This is what I believe, and I think the majority of people believe that this is how it acts. There's lots and lots of evidence to support this. And then once it gets into the nervous system, so there's the midbrain right there, so that's where the substantia nigra is, it can spread into other parts of the brain, into the cortex. So this takes decade after decade after decade, so it's an incredibly slow process. And I'm going to talk about the symptoms that you get are actually related to where the alpha-synuclein pathology is. So that's why the constipation starts very early. And then you have REM sleep problems, the sleep problems when it gets around there. So you can see how the symptoms can develop over time. Okay, so how does this process start? So this is where I spend a whole lot of time. What initiates this process? So, and I'm going to tell you, I think the environment plays a key role. And they say it's on a fertile ground of genetics. So if there's something in the environment that starts it, not everybody gets it. Some people get it, not other people. So we think you have to be genetically vulnerable to it, or you have multiple environmental insults. So we know that only about 30% of Parkinson's can be related to genetics. Now, it's not 30% is inherited, about 5% is inherited the way we think about, inheriting a disease. But there's a whole bunch of normal variations that we all have in our genes that make us individuals, but some of those variations make you a little bit more at risk than other people. And you can add those all up. There's about 18 or 19 of them now, probably a little bit more. We call them polymorphisms. And if you add up all that genetic risk, it's about 30% we can explain. So we may get a few more percentage with time, but we've exploited genetics quite extensively. So that means that it's probably the environment is the other 70%, or at least a big hunk of it. So that's one of the things that we spend a lot of time looking at. The other thing to note is if it starts in the gut and the olfactory bulb, that tells us those are the interfaces that we have in the environment. So if you're driving in Central Valley, you're breathing in all those wonderful pesticides and all the air pollution. Your olfactory bulb and your gut are the first things they see. And so it's kind of a coincidence, I think it's more than a coincidence, that that's where we think that much of Parkinson's starts. All right. So I said about 5% maybe are inherited, and these are just some of the genes. These are the majority of them that there are mutations in them. So we have a whole bunch of these now. We have about 10 of them, maybe a little bit more, that if you inherit one or two copies, if it's dominant or recessive, it's not important. You inherit those, you get the disease. But all of these add up to about 5%. So it's rare, but it gives us clues on what the process may be. So we can learn what each of these genes does. And so the first one was alpha-synuclein. So that was actually gave us a clue to start. And this has all been in the last 20, 25 years. So it's remarkable. It's all been within my career. All of this has been discovered. Now, there are some common themes. So alpha-synuclein is a common theme. You can get a couple copies of it or a mutation and get Parkinson's. Or there's processes that help break down aggregates, those clumps of protein. And many of the genes are involved in those degradative processes. And then there's also the energy source in our neurons called mitochondria. Those are the power plants of our cells, and they seem to be involved. So these are some of the common themes that we see, and that's helped us target where do we start to try to stop the disease from moving forward. Okay, so one of the ways that we look at causes of Parkinson's is we look at what's called epidemiology. We just look at associations. So what are the things that are associated with getting Parkinson's? Well, age is definitely one of them. The older you are, the higher risk you are. It's a disease of aging. Men get it more than women for some reason, almost 1.5 to twice as often. Believe it or not, if you smoke, drink a lot of alcohol, or drink a lot of coffee, you have a lower risk of getting Parkinson's disease. It's an inverse relationship. So don't go smoke. Coffee's good, but anyway, I can explain there's a lot of theories about that, but it's actually a very, very strong association to smoking. Then the bad things. So head trauma increases your risk. People, whether they're boxers, of course, but football players, many repeated head trauma, and it doesn't have to be that severe, increases risk. Exercise lowers risk. Diet lowers risk. These can be quite profound. There was a wonderful study showing the Mediterranean diet. There's actually been a couple studies now that show that people that live a Mediterranean diet have about half the risk of getting Parkinson's. It's a huge effect. So when we say eat well and exercise, it's not just saying we don't have anything else to give you. It actually makes a big difference. Pesticides. Some of them are really bad players, and they definitely increase the risk, and we know how they do it. Same thing with air pollution. And then there's solvents. This is the Camp Lejeune. Everybody hears about that. That actually is due to TCE, which was rampant at Camp Lejeune. And some of the pesticides you may have heard of, paraquat, there's been a lot of lawsuits with that. The evidence for these is actually quite good. All right. So one of the things that's really important to think about is associations don't necessarily mean it causes it. It just means they're associated. So if I said drinking alcohol increases your risk of getting lung cancer, it'd say, no, it's smoking. But the people who drink have a higher incidence of smoking, so therefore they're associated, but they're not causal. So how do we figure out whether it's the smoking or the alcohol? Well, we turn to animal models. And in the animal models, doesn't necessarily, animals don't get Parkinson's disease, but we can recreate aspects of Parkinson's in the animals. So we study different aspects in different animal models, and if we add up the animal models suggest it and the associations are there, then that's a pretty good idea that it's likely causative and not just associated. So that's really important. So I think the smoking is an association but not causative. So one of the ways we study associations, this is my good friend Beata Ritz, who's this world-famous epidemiologist, and we've been doing these huge studies in the Central Valley now for 25 years. We've been following about 1,000 Parkinson's patients. I drive out there once a month. That's why the drive this morning was nothing compared to going to Fresno. But we've worked together and used this, it's called geocoding, but we have this database in California that basically has all the amount of pesticides that have been sprayed throughout California for the last 45 years. So we know where it's sprayed and how much. And so if we knew where you lived and worked, we can get a pretty good estimate of what you were exposed to 45 years ago, 20 years ago, before your Parkinson's started. So this is really important. It's called that lag time. So people say, oh, I got an email just the other day. I got a big spray of this chemical called Xyram, which is probably associated with Parkinson's, and my Parkinson's started a week later. Well, I know it's not that because it started decades before. So this is really important way of researching. So this is just one example. There's many people studying this throughout the world, but this is one of the ways that we found pesticides, certain pesticides are associated with Parkinson's. This is actually a crop duster. There's a school right there. You know, it's pretty horrible stuff. Happens every day in the Central Valley. About 20% of all pesticides in the country are actually sprayed in the Central Valley. So I can't help plug my own research. So one of the biological ways that we try to study these chemicals are using animal models, and in my lab we use zebrafish. So this is actually a zebrafish embryo, and you can see it developing with time lapse, and it becomes a little fish within 1 day. And then within 3 days, it's swimming around already and has a very well-developed nervous system, including dopamine neurons. So one of the nice things about zebrafish is that they're transparent. And so we can genetically modify them. So this is a fish that we made where the dopamine neurons are all fluorescent. And then we can image them and study them in living animals. So we throw some pesticides in there, see what happens to their dopamine neurons, see what happens to the alpha-synuclein, look at the degradative pathways, so we can start to approach whether these associations that I find with Beata Ritz are those associations actually causing it or not. So these are just one of many of the biological studies. And you can see in the fish, this is a fish exposed to one of the pesticides. And this is what that looks kind of like a Lewy body. This is a fish that was exposed to Xyram. So it forms these clumps much like we see in humans. So we think that this, along with the association, et cetera, it's an example of how we determine how something in the environment may increase the risk. So it's just one of many examples. This was the cover of Science magazine about 7 years ago now, and it's only been recently appreciated that air pollution is a real risk factor for Parkinson's, and it actually started with dementia and Alzheimer's. It turns out Parkinson's as well. And if you think about LA, for example, in the 70s, there was a lot of air pollution. And if we do, there's now a number of association studies that if we kind of go back, about 70% of Parkinson's in LA could be due to air pollution. So it's a huge risk factor, we think. It doesn't increase the risk that much, but it affects so many people. Again, it's an association, and we've done a lot of research, and there's a lot of animal studies supporting that association is causative. So I have a whole talk on air pollution and Parkinson's, which I'd love to give another time. So anyway, so let's get back to how can we prevent it. So there are modifiable risk factors, right? You can't pick your parents, so you can't change your genes yet. We're getting close. But we already have some modifiable risk factors, right? So we can help avoid head trauma. We can, make sports a little bit less traumatic for our kids. We can get people to exercise more, diet. We can try to minimize the exposure to toxins such as pesticides. Try to live in Santa Barbara where you don't have much air pollution, and stay away from some of these solvents. So we can prevent a lot of Parkinson's already. So we're already getting there. So we have to be proactive for all these things. All right. So I'm going to switch gears a little bit. So I talked a little bit, very briefly about genes and about the environment. Okay, so Parkinson's has started. How can we slow or stop it? And that's where we want to try to intervene here. And then for those people that already have the symptoms of Parkinson's, that's how you know you have it, we have some symptomatic treatments. So let's start in seeing how do we approach slowing the disease down. So first, when you think about this, how do you start? So when I started in this business about 30 years ago, we knew so little about the mechanism. So they would just try things, oxidative stress, that's those dreaded free radicals, and throw all these antioxidants, and it never worked. Fortunately now, we have a much better handle of all the molecular pathways. I just showed you an overview of those, and we have much more complicated versions of that slide, but we understand a lot more that's going on. So we can use that knowledge to develop drugs to target those pathways. So it's really important to understand when we call it a target, what are we trying to intervene? What part of the nervous system and the cell are we trying to affect to make change? Then we have to recreate aspects of Parkinson's in animals. Just remember, it takes 20 years or 30 years for Parkinson's to develop. Mice and rats only live a couple of years. Fish only live a couple of years. So we have to try to guess on accelerating this process the best we can. And then once we think we have a good target and that drug can interfere and interact with that target or engage in that target, then we have to do clinical trials in people to see if it works. Now, there's good and bad news. The good news is it's a really slowly progressive disease. It takes decades. People can live very long and happy life with what we have today. So it's very slow. That's great. The bad part about it is it takes a really long time for us to figure out whether one of our interventions work. So the process of testing these drugs is very slow, painfully slow. But you have to start somewhere. So we're getting better at it, but that's one of the reasons things are taking longer than we would like. This is just a cartoon to talk a little bit about where we're targeting now. So the drugs that are being developed and being tested now. So there are studies now looking at ways of reducing the expression of alpha-synuclein. So they're genetic, they interfere with the gene and keeps it from, so that basically let's make less alpha-synuclein. If there's less, it's not going to aggregate. These are already in people, these trials. There's some treatments in other genetic diseases that have been proven to work and are on the market now. So this approach is no longer science fiction. Interfering with gene expression is a real thing, and that's in process right now. And not just the gene alpha-synuclein, some other genes that we also know are risk factors for Parkinson's disease. There are drugs trying to prevent the aggregation, the alpha-synuclein sticking together. So that target is to prevent that clumping, which we think will help reduce the toxicity. We have drugs that try to get rid of those alpha-synuclein clumps, ways of improving that degradation. Remember I said that was one of the central themes in what causes Parkinson's is the inability to get rid of these toxic molecules. So there are drugs that can enhance that, and those are being tested right now. There are drugs that are tested on the spread. So like I said, we release alpha-synuclein aggregates, it spreads to the neighboring neuron. So one of the drugs is, there are antibodies, so that binds to alpha-synuclein and prevents the spread. Works beautifully in animals. We've cured Parkinson's in mice many times. And there's some evidence that it may be working a little bit. There's also a lot of inflammation in the brain. That's something I haven't talked a lot about. I personally don't think it's the thing that starts Parkinson's, but it does seem to enhance it and seem to keep it going. So it may be an important target. So there's anti-inflammatory drugs that are being developed. So you can see that's just a handful of the approaches that are being tested now, and all of these are already in trials. This is, obviously can't read it, I can't read it. It's just to give you an idea of how many different trials. These are ongoing trials and all the different targets. There's pages of this, so it's really optimistic. This is going on, it's a serious effort, and I'm very encouraged by all the progress that's been made in Alzheimer's disease. Alzheimer's is probably a harder one to get, and they have antibodies now that actually slow the progression of Alzheimer's. It's very exciting. It's just the beginning. It needs to be improved. But the fact is, it's begun. We're seeing the very beginnings of slowing neurodegenerative disease progression. So that's really a big deal. So this is one of those trials in people. So this is an antibody made by a company called Prothena, and they gave this antibody to people that just got Parkinson's, newly diagnosed, and the people that got the antibody progressed slower than the people that didn't. Now, it's not a huge difference, and it was smaller than we had hoped, so it wasn't considered a huge success. This has actually been taken out now about 5 more years, and you're starting to see that you separate more. Now, I don't think this is going to make the market. I don't think that's a big enough difference, but it's the beginning. It took about 13 different antibody trials in Alzheimer's to get one that hit. So this is the second one. So the first one failed. It was a different company called Biogen, and it didn't work at all. This one seems to work maybe a little bit. So one approach, starting to show a little bit of evidence. It's a little bit, but it's very encouraging. We do have one therapy that absolutely slows the progression. And everybody's insurance covers it, and it's exercise. So these are real studies. There's tons of studies. So this is Lancet, it's a very important journal, JAMA, another important journal. So if you look at people, this is before, so higher bar is worse. So this is before and after, like I think it was 6 months. And you can see in the treatment group, this was actually a year, if I remember, they actually got a little better. People who didn't got worse. This is progression. This is stopping progression. Completely different study. These are blinded the best they can. Again, people with high intensity exercise barely progressed over a year. People who didn't progress, who didn't exercise, got worse. So it's a big deal. So doing exercise regular, and don't ask which one, it doesn't matter. Whatever you enjoy doing, do it. Just keep moving. It's so important, both physically and mentally. All right. So that's just a little bit of how we're addressing progression of the disease. We call that disease modification. One of the things that we do reasonably well is treat the symptoms. One of the reasons that I got into movement disorders is levodopa was this miracle drug. We only had about 3 drugs when I was training in neurology, and levodopa really made a huge difference. And even after 50 years of the drug, it's still the best one we have. So I'm going to talk a little bit about the symptomatic treatments. Now, one of the things that's a little different than what most people talk about, usually we talk about dopamine, right? We talk about levodopa, we talk about Comtan, we talk about all these different dopamine drugs, and I'll talk a little bit about that. But as I said, it starts in the gut and goes through the whole nervous system. So there are many, many symptoms and problems that people have due to Parkinson's that previously weren't recognized that we now know are part of Parkinson's, but we can treat many of them. So those problems reflect where the pathology is. Where are those clumps of alpha-synuclein? Where are they injuring those cells that cause the symptoms? So I'm going to try to, this is the first time I'm actually going to try to do this, is try to associate the symptoms with the location and the chemical basis and how we approach to treat that. All right, so let's start with one of the earliest places it starts, called the autonomic nervous system, and that controls the gut. We could talk a whole lot about the microbiome that's in the gut, and that may be very important. We're studying that. That may be part of what starts it, but we know constipation is a big problem in Parkinson's. It's part of the disease. It's not just the drugs we give, but it's part of the disease. So we can give laxatives for that. There's actually a drug called prucalopride or motegrity, actually can stimulate the contraction, because what happens is the GI system normally contracts and helps keep things moving. It doesn't work as well. So we have either using medicines, or the best way is diet, right? High fiber diets are really good for helping that. That's the best thing you can do. But if that's not enough, we have a variety of laxatives and now medications to help keep things moving. We have blood pressure problems. That's also part of the nervous system. Sometimes people stand up, they get really lightheaded. It's because their blood vessels are not contracting as well. And it's called orthostatic hypotension, you know, when people can even pass out. So we have medicines for that, but we also can control that with diet by eating a lot more salt and staying well hydrated. Things like urinary frequency, people going to the bathroom too often, having to get up 3 or 4 times a night. It might be the prostate, but it might be your bladder is contracting too much, or the control valve that keeps it in doesn't work quite as well. We have ways of treating that. So we have treatments. We do have treatments for these. This is called a non-motor symptom. It's all part of what we call the autonomic nervous system. So we don't think of all this as part of Parkinson's treatments, but it really is a critical part of it in how we practice today. All right, so sleep disorder. So this part of the brain stem right below the midbrain is called the locus coeruleus and areas around it. When that gets affected, that's when people get what's called REM sleep behavior. So it turns out that this is when you act out your dreams, and you may be punching your bed partner. It can be very serious, actually. It turns out that for many people, it's the very first symptom, and if you get REM sleep behavior as an adult, there's a very good chance that you will eventually start manifesting Parkinson's disease. And once you have it, many, many people have that as well. So we know that this involves serotonin and norepinephrine, and so we have medicines that address these chemicals. So we have ways of addressing it. So I'm going to always emphasize the non-pharmaceutical ways first, because that's how I think medicine should be practiced, very holistically and naturally, which is exercise, a good diet, and good sleep hygiene. Going to bed on time, not looking at your phone or your computer all night. Good habits, good sleep hygiene, very, very important. You know, that we have treatments for insomnia, we have treatments for REM sleep behavior, lots of medicines if those sleep hygiene methods don't work. So many ways to address it, but sleep is really important. That's one of the key features. Not only do you feel better, but it actually probably slows the disease progression down. It's a whole nother discussion. Now, of course, now we're where everybody is used to hearing about. We're in the midbrain. We're working our way up, and this is when people start getting all the symptoms of not enough dopamine in their brain. Those dopamine neurons are affected. So this is a blow-up cartoon of how we make dopamine. So dopamine is made in the brain. It's normal. We take a natural amino acid called tyrosine. We convert that to levodopa in our brain, and then convert that to dopamine. You release it, and then it binds to the receptors on the neighboring neuron to help you move. So it turns out that people with Parkinson's don't have enough of this enzyme right here, but you have plenty of the enzyme here. So we don't give tyrosine because it can't make levodopa, so we give levodopa. So that's what you're actually taking in Symptomatic is levodopa. So you're actually replacing something your brain normally makes. It's deficient. That's why it's the best drug. Now, there are problems with it. It doesn't stay in your blood system very long. Protein interferes with absorption, so people have tried to make synthetic dopamine. They're called dopamine agonists, things like Pramipexole or Mirapex or Requip, Ropinirole, Retigotine, the patch. They have some advantages because they're designed to be absorbed well and last a long time. You can have patches, injections, but they don't work as well and they have side effects. So they have advantages and disadvantages, and we use some of that as well in cocktails that we often come up with depending on your symptoms. One of the I'm not a plant for AbbVie, by the way, but I'm going to be talking about it in a minute, is one of our goals is to make the dopamine levels in the brain nice and smooth. It turns out that the brain normally has stable levels. And so we want to do what's called continuous stimulation and make it as stable as possible. And not just give huge doses twice a day, which would be more convenient, but it turns out that that causes problems over time. So that's when you get the dyskinesias, those involuntary movements, from getting what we call pulsatile stimulation. So we're trying to get it as smooth, and especially when you've had the disease for a number of years, people's condition goes up and down. You go this cycle of feeling good or moving too much and then not moving enough. So we want to make your quality of life as smooth as possible, but it also is good for you in the long run. So that's why we have all kinds of different formulations now. This is just a cartoon that was actually made a number of years ago. It's still true. So when early on in the disease, which is different for every single person, you can take a lot of Symptomatic or a little bit, and you're in this therapeutic window where people feel great. And as the disease goes on, it's harder and harder to find just the right amount. Either you have too much and you move too much and you have the dyskinesias, or you have too little and you're slow and stiff and you have the tremors. So we're trying to make it in this sweet spot. So how do we do that? So we have lots of new formulations. I actually saw a booth for Rytari. That's one way to smooth it out. It's short, medium, and long-acting all in a capsule, and that helps. It's not perfect, and it's not great for everybody, and it's way too expensive. But it's a very good alternative for many people that have problems with hitting that sweet spot. This is Duopa, which most people don't like, which is a tube that gets surgically inserted into your stomach and intestine, and then you have this pump, and you pump in a form of levodopa continuously. It works really well in smoothing out the levels. It's fantastic. It really works. But people don't like having to carry this big pump around and have a tube put in their stomach. But it was a proof of principle. So it hasn't been all that popular, but it really got people thinking, how else can we smooth things out? There's different ways. So some people rescue inhalers. So there's a drug called Inbrija. You inhale it and you can get, so if it takes a long time for your medicine to kick in, that may give it a boost and tie the doses together. There's a sublingual dopamine agonist. So you can see there's a whole bunch of these medications to try to smooth things out and make stimulation of dopamine nice and continuous. So this is one I think many of us are looking forward to. We've been part of these trials, actually been part of all these trials. This one I'm particularly hopeful. There's two companies making a subcutaneous form of pump. I think I even have some pictures. So this is Duopa. This is the big pump. It's actually quite large and heavy. You have to put in the tube and carry this around. But this is what you get from it. Nice, stable blood levels. That's what you want. And I want you to see here. So this is 3 micrograms per ml. That's an important number. So this is AbbVie, who has a new pump. that has been approved in Europe now just a few weeks ago, I think, or a month ago, and in Japan. We've done the study with, and this is the size of the pump. It's smaller. People still don't like it, but it's much better than the previous ones. But look at how nice and smooth that blood levels are, right around 3 micrograms per microliter, which is exactly the levels that we found you need. And these red dots are people taking Symptomatic. So this is what happens when you take Symptomatic. It goes up and down, and this is what happens if you have a nice, even delivery. So this is very exciting for those people that are having problems finding that sweet spot. This is going to be a big help. This is just some of the study results from the study that we were actually involved with, just showing that people's on time, feeling good without extra movements and problems are much, much better. It's a very large effect. This is the other company that's making it. This is called Neuroderm. And I think they're pretty close as well. Their blood levels don't get quite as high, so they don't quite reach that 3,000 or 3 milligrams per ml. And so in Neuroderm, they need to take extra Symptomatic in addition. So it's been very helpful. But I think personally, I think the advantage goes to the AbbVie one just because they can reach higher blood levels. Hopefully these will be on the market by the end of this year. We've been hoping, but we have to wait and see. I don't think there's any major obstacles. So I think this is going to be a nice option for some people. This is another type of pump. This is also available in Europe, and we did some studies with it. It's called apomorphine. This is what the pump looks like. Also gives nice continuous things. It has a little bit more side effects than levodopa, but it's quite effective as well. This should be an option relatively soon. These studies have all been completed. These are the little needles that you have to insert every day. All right. So that's our approach to treating the dopamine deficient syndrome symptoms, the tremors, the rigidity, and things like that. How about some of the problems when you start get to higher cognitive function? So fortunately, this doesn't happen to everybody, but some people start having memory problems, forgetfulness, that's low in acetylcholine, another chemical in the brain. Many people get anxiety and depression. It's actually a really common part of Parkinson's, and it's not just because you've been diagnosed. They've done studies to show it's much higher depression and anxiety in Parkinson's patients than with people with ALS or Lou Gehrig's disease, which is a much worse disease. So we believe that that's the case because they're really low in serotonin, norepinephrine, and dopamine as well. So I really stress this to my patients. If you feel anxious or depressed, it's like your tremor. It's a biochemical deficiency. It's nothing to be embarrassed about, and there's good treatments. That's the good thing about it, is we have great treatments for increasing serotonin and norepinephrine. Hallucinations. Unfortunately, that can happen as well, and it's a combination of our medications cause them as well as the disease. Now, we think a lot of that is from too much dopamine, so we have treatments to help reduce hallucinations or even stop them completely. Both the combination of getting rid of medicines that may be contributing, but also using medicines that help suppress them. Doing okay. And then we have problems if it gets in the frontal lobe, we call it executive dysfunction. So that's people getting, having problems multitasking, for example. That's a real problem for people with Parkinson's. So we have strategies. We don't have good medicines for it, but we have strategies to help people figure out how to focus on one thing at a time, for example. Don't try to multitask. If you do a single task, you're going to do much better. Apathy is a big problem, part of the executive dysfunction. Really trying to do social things like this, for example, it helps motivate people, get them out, keep them moving, and helps prevent some of those other problems. And I didn't mention, we do have medicines that increase acetylcholine. Donepezil, rivastigmine, some of these medicines that were actually developed for memory disorders, for Alzheimer's and stuff, have some benefits in Parkinson's as well. Okay. So now when all of these things fail, at least for the motor symptoms, not for the cognitive part, just the motor symptoms, we have some a little bit more aggressive treatments, a little more invasive. So these are called stereotactic or functional surgeries that we do. I see all the 3 vendors are here that make deep brain stimulators. I'll talk a little bit about that. One of our newer treatments that we have called Focus Ultrasound, and talk very briefly about some experimental therapies with stem cells. So the basics of deep brain stimulation are a couple things that I think everybody needs to know. So we have now 3 companies that each have their own pros and cons, but they're all great, and all 3 of them work really well, and the technology's improved. This was approved in 1998, so we've been doing this for over 25 years, and the technology keeps improving. We can put them in different parts of the brain. Not important for you other than to say both parts work pretty well and can treat these ups and downs. The motor fluctuations is what it does. There is one other place, a third place we can put it, and that only treats tremor. So we tend not to use that very often in Parkinson's because even though the tremor can be bothersome, we have the other symptoms we want to treat as well. So we save this for just certain individuals that have just tremor. One important concept about surgeries in Parkinson's is that you don't ever get better than your best on time. So if you take your Symptomatic and you say, I take it every 3 or 4 hours, and I have 1 hour that I'm doing great. I'm not having the extra movements, I'm not too slow, I feel great. Surgery can get you more of that, but it's not going to make you a whole lot better than that. So that's really important. So if you have a lot of tremor that goes away or stiffness that goes away with your medicine, this can really help. But if you have balance problems, even when your medicine's working and your doctor says and your therapist says you need to use a walker or you're going to fall, you still need to use the walker. Your balance is not going to get better if the Symptomatic didn't make you better. So that's a really important concept. It doesn't change how fast the disease progresses. It doesn't slow it down, it doesn't speed it up, it treats the symptoms. So that's why I put this in the symptomatic treatment category. And again, it only gives you more of the good times. The exceptions are it lowers the amount of involuntary movements. It's really quite striking to me seeing all these people out here, and I don't see anybody with a lot of dyskinesia, so your doctors are doing a good job here. But it really can treat these extra movements, the involuntary movements, the dyskinesias, but also can treat the tremor. Sometimes the tremor is not treated as well by the medication, and DBS can do a little bit better. So those are the basic concepts. These are some of the places in the brain where we put them. The surgeon puts them. So you can put it here in the globus pallidus. Here is called the subthalamic nucleus, STN, and the nigra is very close, just right under there where the dopamine cells are. So you can see that it takes a very skilled surgeon. They have a couple millimeters leeway, 1 millimeter leeway has to be right on. Now, fortunately, they have these electrodes that have 4 different contacts, and now the newer ones have break them up into what we call segments. So it gives us lots and lots of ability to stimulate different regions of those nuclei so that we can find the best spot. So it takes a little bit a while to program it just right. But with a little time, over a course of months, we get it and we can fine-tune it. This is what it looks like. This is all under the skin. This is Medtronic, actually the first system that came on the market, and it gets implanted. It's a pacemaker-like thing. Goes under the skin, and we put electrodes deep into the brain and connect the wire. It goes under, behind the neck, under the skin, and then we program it wirelessly. This is what it looks like in the operating room. So this is actually under the, so people, we wake them up in the operating room after we drill the hole. People have no pain, and we actually examine people so that we can see, is it helping? Are we in the right spot? So we do lots of things to make sure we're in the right spot. We have imaging, we have electrode recordings that are here, so we're in the right spot. And then we test it as people are awake, and then we record that. So that's DBS. We've been doing it for 25 years. We're getting better and better at it. But people don't like to have surgeries. I don't think anybody does, or you shouldn't want to have surgeries. So people have looked at less invasive ways of doing it. So this is a technique that's called focus ultrasound. And it was just approved for Parkinson's in the globus pallidus, but before that we can only do the thalamus. So again, it's for tremor. So, and what it does, let me see if I have a slide, is it burns a little hole deep in the brain. So before we did DBS, or deep brain stimulation, we used to actually put an electrode in and burn a little hole. And it turns out that if there's certain areas of the brain that are overactive. If we make them less active with burning a hole or stimulating to block it, we can improve the symptoms. So this is a less invasive way. So you put on they put on a frame, and you go in the MRI scanner. You can see here, and then what they can do is they focus a beam of ultrasound, and you can measure the temperature in the brain while this is going on. And so you do it to burn a little hole, and it improves the tremor. So here's somebody with a central tremor and trying to make these squiggles, and then by the end, they can make a nice smooth. It's quite dramatic, but it is giving a little stroke, a very controlled stroke. You can see it, it's right there, deep inside the brain. So there's a risk of side effects. About 20% actually will get side effects, and almost all of them go away. But sometimes you hit an area that, can cause you a little weakness or a little bit of unsteady gait. So it's not perfect, but it's another way that's improving and giving new options in treatment. So like I said, it just got approved. Insurance hasn't started paying for it yet in the globus pallidus. We used to do a lot of pallidotomies in those days. It can be very effective, but we only do one side at a time, and you have to wait a year, because when you do both sides, you have a higher risk of side effects. So this is still being developed, and where it's going to fit in, that's why we sit and we come up with what's the best option for that individual. So there's not one best treatment, it's what's best for that person. All right, so everybody always likes to hear about stem cells. And it's starting to become a possibility. But I do want to start by saying this is not really all that new in some ways. So, good 30 years ago, there were fetal cell transplants. And what people did was they take aborted fetuses, they cut that midbrain part out, culture them up, and that's where those are, we call neurostem cells. They're progenitor cells in the brain, and they got implanted into people with Parkinson's disease. So those were called fetal cell transplants. And now when I started, they had done a whole bunch of them, and it was remarkable. It was going to cure everything. until they did control studies. And that's having a placebo group, basically sham surgery. And we learned a lot from those studies. So we learned, number one, that they can live in the brain and they can stay and produce dopamine in those areas. So that's good. But they only help certain patients, not all of them. And some people, actually, it made too much dopamine, we think, and they got the dyskinesias even without taking the medication. So there was a loss of control of those cells. Now, whether there's a lot of controversy of why that occurred, but that was seen in all the studies that have done controlled trials, and it was actually many of the people that got benefit from those fetal transplants actually had to have DBS to control the dyskinesias. So these are some of the concerns that we had moving forward. Couple of other important lessons that we learned, and it's not surprising, is it's a symptomatic therapy. It does not change, it's not a cure for the disease. It treats only that dopamine part of the symptoms. So it's not going to change your memory, good or bad. It's only treating those symptoms, the same symptoms that DBS treats. So it's very, very important. On the other hand, we learned a lot from stem cells. So number one, from these fetal transplant, those transplanted cells actually got Lewy bodies in them. So that's one of the pieces of evidence that said this is spreading. So it took most people 60 years to get a Lewy body. It took those neurons less than a decade to get it. So we know something in the environment of the brain was causing that Lewy body to form in those young transplanted cells. So what we've taken all these lessons, and many of these things can hopefully be overcome. So the source of the cells is much better, right? None of us like the idea of using aborted fetuses and chopping up the cells, and each one would be different. So we don't have to worry about that with stem cells now, because you can grow them up in a dish and everybody can get a whole bunch of them and all the same. So there are stem cell lines that have been developed, some of them from embryonic stem cells and some from either fibroblasts from the skin, or you can make them from the blood, from fat cells, and you can induce them. That's what the iPS cells are. So we have new source of cells that can be tested for safety, also make sure they turn into dopamine cells and not other types like serotonin cells, which we think may have been contributing to those dyskinesias. We can turn them into dopamine cells. So you can grow up a whole bunch of them, turn them into dopamine cells, make sure they're not making serotonin in that part of the brain we think is bad. And hopefully that will improve some of those problems. We have better delivery methods. So when they did the fetal cell transplants, basically, and I've seen this done, they sit in the operating room with a syringe in their hand, and the surgeon's literally just pushing it slowly. Now they have it automated, and in such a way it delivers it nice and smooth throughout the regions of the brain that you want them. But I personally think the biggest thing that we're going to get from stem cells is understanding what's going on in individuals. So we're just starting a project with this very amazing scientist at Cedars, Clive Svensson, who can make stem cells quite easily from people. He's made 1,000 different lines for ALS, and we're working with him now so that we can understand what is going on in an individual patient. So I started the talk with many different ways of getting Parkinson's. That's probably why everybody's a little different, right? Every person with Parkinson's is an individual, progress in a different way, have different problems. It's probably at least partially affected by why you're getting it, what part of your cell is not working well. And so if we can figure that out in your own cells, make your stem cells and figure it out, we can then tailor the treatment to you. So to me, that's the most exciting part of stem cells. But of course, most people with Parkinson's say, how can that help my symptoms as a treatment. And so many years later now, we're talking about 30 years later, we're starting trials with stem cells now because they've overcome many of those problems. And the study, there's a large study that I can't talk about it now, but they've done 12 patients in figuring out the dosage. It's called the Blue Lock trial. And there's going to be a number of sites. We're going to be one of them where it's going to start doing real experiments, and people can, we'll see if it works. So trying to take all the lessons learned from those fetal cell transplant studies. All right, so just to summarize this whole trip we went through from start to finish, how would I summarize it? Saying, well, we know both genes and the environment are really important, and that's what causes Parkinson's, is a combination and interaction between multiple genes and multiple environmental risk factors, and coming together cause the disease. And now we treat the symptoms. We're getting better at it all the time. But now we understand a lot about what's going on with the genes and the environment, that we can start targeting the underlying pathology, and again, not just throwing, antioxidants at it and hoping that's going to work, because it hasn't. And as we learn more and more about it, and we see the responses from these therapies, we're eventually going to get there. So we're getting very close, and I think with that, just some of the people, so we've been growing our group at UCLA and have all these are the people that are going to find the cures, all these people doing great work. And I do want to point out one person on here. So Dr. Thordarson, Danny, is going to be starting a practice in Calabasas. So we're getting closer to Santa Barbara. She is wonderful. And so she's somebody who I hope many of you will get to know with time. With that, I want to thank you very much, and I hope that was somewhat coherent.